I am really thankful to Dr. Vitul for inviting me and giving me this opportunity to come to this place and interact with you people. What I am going to talk to you today is diabetes ketoacidosis. I tell my residents, it is very easy to remember about diabetes ketoacidosis. It has got 3 words: diabetes ketoacidosis. Diabetes means high blood sugar, ketones means ketones are positive, and acidosis means patient is having acidosis. So it is diabetes ketoacidosis. How you diagnose the patient to be suffering from diabetes ketoacidosis? Diabetes, blood sugar to be more than 200 milligram per deciliter, or patient is having prior history of diabetes. Ketosis, if blood ketones, beta hydroxybutyrate is more than 3 millimole per liter, or urine keto strip is showing 2 plus ketones. Acidosis means pH should be less than 7.3 or bicarbonated less than 18 millimole per liter. 3 DKA, diabetes ketoacidosis. आ गया इसमें तीनों भाई, DKA. Initially we were considering blood sugar to be more than 250. Now the criteria has been changed to 200 milligram. Or even if the blood sugar is normal, patient is having history of diabetes and ketones are positive and acidosis is there, you diagnose the patient to be suffering from diabetes ketoacidosis. Another acute complication that comes to your mind is hyperosmolar coma. How would you differentiate between the two? Both are having polyuria, polydipsia and weight loss and dehydration, but nausea, vomiting and abdominal pain is more common in acidosis, and often diabetes hyperosmolar coma often co-represent with other acute illnesses. Ketoacidosis patient is usually alert, hyperosmolar coma patient is rather very drowsy or unconscious. Ketoacidosis develops in hours or days, hyperosmolar coma develops in days to week. Often patient is having other comorbid condition along with this, like cerebrovascular accident, myocardial infarction, pneumonia. But in diabetes ketoacidosis, patient might not be having underlying disease. Just stoppage of insulin might have led to the diabetes ketoacidosis. And 1/3 of the patient are having both the condition together. What are the causes of morbidity and mortality in diabetes ketoacidosis? First, you have to look for the precipitating illness. Myocardial infarction, stroke, sepsis, pancreatitis and pneumonia. Because if you don't take care of these things, these might take the patient away. Then patient can develop acute renal failure, acute respiratory distress syndrome, vascular thrombosis. Along with that, patient can develop shock, hypokalemia during treatment, hypoglycemia during treatment, cerebral edema or hypophosphatemia. You have to look for these complications and take care of them. What are the pathophysiology of DKA? Why the patient develops a diabetes ketoacidosis? There is absolute insulin deficiency plus there is stress, infection or insufficient intake. So there is a counter-regulatory hormone excess. What are the hormones which oppose the action of insulin? Glucagon, catecholamines, cortisol and growth hormone. There is excess of these. What they lead to? Glycogen lysis means breakage of stored glucose and new protein synthesis, that is gluconeogenesis, new gluconeogenesis by protein lysis. Protein is broken down and it is converted to glucose. It leads to hyperglycemia, glucosuria, loss of water and electrolytes, dehydration and impaired renal function. Increased lipolysis. What it leads to? Increased lipids are catabolized. It leads to increased free fatty acid used, increased ketogenesis, increased ketones body formation, which are converted to keto acids. So what it ultimately leads to? Uncontrolled gluconeogenesis leading to hyperglycemia, Osmotic diuresis leading to dehydration. Unchecked ketogenesis lead to ketosis, which are broken down to hydrogen ions and ketones bodies, which leads to anion gap metabolic acidosis. So, high blood sugar, dehydration and metabolic acidosis. Often a precipitating event like infection and lack of insulin is also there. How you diagnose a patient to be suffering from diabetes ketoacidosis? Any diabetic patient who comes to you with nausea, vomiting, thirst, polyuria, shortness of breath or abdominal pain, suspect the patient to be suffering from diabetes ketoacidosis. What do you feel on signs? What are the signs that you would look for? Tachypnea, Kussmaul respiration, respiratory distress, dehydration or hypotension, tachycardia, abdominal tenderness, lethargy, cerebral edema or possibly coma. What I tell my residents, any diabetes patient who is unconscious, is dry, having difficulty in breathing, look for diabetes ketoacidosis. Any diabetes patient who is unconscious, is wet, is sweating profusely, it is hypoglycemia. So these are the differential. So clinically, any diabetic patient having nausea, vomiting, having difficulty in respiration and dry, look for diabetes ketoacidosis. How you confirm the diagnosis? Just check the blood sugar with glucometer, more than 250, check the blood ketones, more than 3 millimole per liter, or check the urine ketones, more than 2 plus, patient is diagnosed to have diabetes ketosis. If you have got the facility of ABG, get the ABG, pH is less than 7.3, patient is having diabetes acidosis as well. Such an easy thing to make a diagnosis. So you have made a diagnosis of diabetes ketoacidosis. High blood sugar, ketones are positive, patient is acidotic clinically and biochemically. How you are going to manage the patient? First is where to keep the patient. Assess the severity of patient, diabetes ketoacidosis. Look at the mental status. Patient is stuporous or coma, it is severe ketoacidosis. Patient is drowsy, it is moderate. Patient is alert, it is mild. Look at the pH. pH is less than 7, it is severe ketoacidosis. 7 to 7.25 moderate. 7.25 to 7.3, it is mild ketoacidosis. So what an easy diagnosis. Look for the bicarbonate. More than 6, severe ketoacidosis. 3 to 6, moderate. 3 to 6, mild. More than 6, it is severe ketoacidosis. So a patient who is stuporous or comatose, pH is less than 7, bicarbonate more than 6, is severe ketoacidosis, should be managed in ICU. Patient who is drowsy having moderate ketoacidosis might be managed in HDU, and patient who is alert having mild ketoacidosis might be managed in general ward as well. This is one page statement which is available on the net. You can put it in your emergency, all the nursing homes, and to manage so that your junior resident can manage the ketoacidosis themselves. What are the 3 basic principles to manage the diabetes ketoacidosis? IV fluids, number 1. Second is potassium. Third is insulin. It is not that the insulin comes number 1. First thing is IV fluid, IV fluid, IV fluid. Then you have to take care of, we would discuss each and every step, IV fluid, potassium and insulin. First thing you have to give IV fluid. Then avoid hypoglycemia during the treatment. Give the dextrose when the blood sugar comes below 250. And transition to subcutaneous insulin is also important. So first thing we are going to discuss is fluid for diabetes ketoacidosis. When the patient comes to you, first thing is to start with normal saline. 1.5 liters over 2 hours, 500 ml rush, next 500 ml rush, next 500 ml rush. 1.5 liters in 2 hours. By the time if the sodium report is available, depending on the sodium level, if the patient is having low sodium, give normal saline. If the patient sodium is normal or high, give half normal saline. at the rate of 250 ml per hour. But when the blood sugar becomes less than 250, by fluids and by insulin, give dextrose 5% or dextrose normal saline. Don't stop the insulin and don't continue with the normal saline when the blood sugar is less than dextrose, when the blood sugar is less than 250. Because if you don't give the dextrose at that time, patient would land up in hypoglycemia. So fluid, first thing to be given is normal saline fast at about 700 ml or 800 ml per hour, 1.5 liter in first 2 hours, then shift to 200 250 ml per hour. Then when the blood sugar comes less than 250, shift to dextrose. This is the IV fluid. Fluid. This is the treatment. This is the first line treatment. Then comes insulin. Insulin is for the management of acidosis, not only to lower the blood sugar. Whenever we speak about insulin देना है डायबिटीज कीटोएसिडोसिस में, मैं अपने रेजिडेंट से पूछता हूँ वन कॉन्ट्राइंडिकेशन टू गिव द इंसुलिन इन डायबिटीज कीटोएसिडोसिस. आप सबको पता है इंसुलिन देना कीटोएसिडोसिस में. एक कॉन्ट्राइंडिकेशन भी है, किसमें आपने इंसुलिन नहीं देना. इफ द पोटाशियम इज लेस देन 3.3, डोंट गिव इंसुलिन. फर्स्ट यू करेक्ट द पोटाशियम, देन यू गिव द इंसुलिन. If the potassium is more than 3.3, give insulin. If it is less than 3.3, first correct the potassium, then you give the insulin. If pH is less than 7 or some people say less than 6.9, then only give the bicarbonate. Insulin is given to correct the acidosis and correct the ion gap, but also to low blood sugar. But even the blood sugar has become normal. If acidosis is persisting, continue to give the IV insulin. What should be the rate of giving the insulin? How much insulin you should give? This is an important thing to remember. कि इंसुलिन देना कितना, आपके पास कीटोएसिडोसिस का पेशेंट आ गया. 0.1 यूनिट पर केजी पर आवर. एट स्टैट पेशेंट को इन्फ्यूजन में देना है. इन्फ्यूजन लगने को टाइम लग गया, घंटा लग गया, आधा घंटा लग गया. इन्फ्यूजन पंप इज नॉट अवेलेबल. गिव एन IV पुश. 0.1 यूनिट पर केजी स्टैट. 60 किलो का पेशेंट आया आपके पास, 6 यूनिट इंसुलिन उसी को लगा दो उस समय IV. देन स्टार्ट विथ 6 यूनिट्स पर आवर विद इन्फ्यूजन till the blood sugar comes less than 250. When the blood sugar is less than 250, reduce the rate to half. That is about 3 units per hour. Along with that, you give the patient dextrose. But this rate is not 100%. This depends on patient to patient. आपके पेशेंट का शुगर कम ही नहीं हो रहा, आपने उसको 6 यूनिट्स पर आवर पे इंसुलिन दिया. What should be the optimal rate of fall of blood sugar in a diabetic patient? About 30 to 50 milligram per hour. पेशेंट का शुगर कम नहीं हो रहा, आपका पेशेंट आया 460 ब्लड शुगर है, 2 आवर्स बाद भी उसका 450 ही है. Would you continue with the same dose of insulin? No. Increase by 25%. If the blood sugar fall is not optimal, increase the rate by 25%. Even if the patient is not responding, you are giving proper IV fluids. पेशेंट को फ्लूइड भी दे दिया 2 लीटर, 2.5 लीटर, 3 लीटर. Even then the blood sugar is not falling, might be you have to give more insulin. Patient is having severe infection. Insulin resistance है पेशेंट का. Patient obese है, might be 0.1 unit per kg is not acting. So this dose is not generalized rule, but you have to see the individualize the treatment depending on the patient. So हमने फ्लूइड डिस्कस कर लिया, इंसुलिन डिस्कस कर ली. पोटाशियम, आपके पास पेशेंट आया, उसका पोटाशियम इज अराउंड अबाउट 5.2, 5.3. पेशेंट का पोटाशियम तो नॉर्मल है. शुड वी गिव द पोटाशियम टू दिस पेशेंट? यस, पोटाशियम हैज टू बी गिवन बिकॉज लाइफ थ्रेटनिंग हाइपोकलीमिया कैन डेवलप ड्यूरिंग इंसुलिन ट्रीटमेंट. पोटाशियम री एंटर्स अ सेल व्हेन यू गिव द इंसुलिन and extracellular potassium falls suddenly. In a diabetes ketoacidosis, because of osmotic diuresis, potassium is lost in the urine and patient is having potassium deficiency as well. What are the guidelines to replace the potassium? If potassium is between 3.3 to 5.2, in each dextrose 5% or each normal saline you give 1 ampule of potassium chloride. 20 milliequivalent of potassium in each 1 bottle of dextrose 5, 1 bottle of normal saline. That would be sufficient. But if potassium is less than 3.3, give only normal saline with potassium, don't give insulin, as already have been discussed. But if the potassium is more than 5.2, don't give the potassium. First give the normal saline, first give the insulin, bring the potassium less than 5.2, then only give the potassium. अब मेरे पास रेजिडेंट पूछते हैं, सर हमारे पास तो पोटाशियम की रिपोर्ट 3 घंटे बाद आती है. पेशेंट आपके पास आ गया, पहली बॉटल में दूसरी बॉटल में आपने पहले 1 लीटर फ्लूइड दे दिया, 1.5 लीटर दे दिया, अब पोटाशियम देना या नहीं देना कैसे डिसाइड करें? रिपोर्ट तो अपने पास है नहीं. And ABG is there, in DMC ABG is there. Many of the centers are not having the facility of ABG. Then how would you decide whether the potassium has to be given or not? Look at the patient clinically. Patient is passing good amount of urine. Get an ECG. ECG is not showing hyperkalemia, tall T wave, replace the potassium. If the patient is anuric, patient is not passing urine, get an ECG, ECG is showing tall T wave, don't give the potassium. ECG is showing U waves, give potassium, don't give the insulin. So you can detect the potassium level, have the estimation of potassium level by an ECG done at the 0 time without having the serum potassium level from the lab, which would come after 3 hours. So potassium की guidelines हो गई, अब IV fluid की guidelines हो गई, insulin की guidelines हो गई, contraindication to insulin हो गया, potassium की contraindication हो गई, potassium की indication हो गई. Fourth thing people ask, when should you give bicarbonates? Bicarbonate, 99.90% of the patient would not require bicarbonate administration. It should be given only if the pH is less than 6.9, patient is unconscious and on vasopressor, not responding to IV fluids. Then only you should give soda bicarb. That also 1 ampule in half normal saline over 1 hour until the pH is more than 7. After that you should not give soda bicarb. Why? Because it leads to hypokalemia and it shifts the oxygen dissociation curve to the left, patient develops hypoxia. You should avoid soda bicarb as much as possible in diabetes ketoacidosis. Treatment of diabetes ketoacidosis is IV fluid, insulin and potassium. Soda bicarb should be given only in a desperate situation. Okay. Patient को आपके पास आया unconscious, you have given the IV fluid, you have given the insulin, you have given the patient potassium. Patient has become conscious, patient has started taking orally. अब क्या करना है? When the patient has become conscious, semi-solid or liquid diet patient has started accepting, you should shift the patient to subcutaneous insulin. What are the criteria in which patient should be shifted from IV insulin to subcutaneous insulin? When the blood sugar is less than 200, venous pH is more than 7.3, bicarbonate are more than 15, in iron gap is less than 12 milli-equivalent. You should start with subcutaneous insulin. Although ketones might be positive even at that time, you should not you should not that the ketones are negative, only then you would stop the IV insulin. If the pH has resolved, bicarbonate has become normal, blood sugar has become controlled, you can shift to subcutaneous insulin. How you shift the patient from IV insulin to subcutaneous insulin? What is the dose you have to give? First thing, how much, when you should give? When the patient has started taking orally or accepting relative feed, acidosis has disappeared, start subcutaneous insulin. Which insulin to be given? Both basal as well as rapid acting. Analogs are better than the traditional with the human insulin because it leads to less of hypoglycemia. Important thing is there should be an overlap between the IV insulin and subcutaneous insulin. When you give subcutaneous insulin, IV insulin should be stopped 2 hours after giving subcutaneous insulin. Why? Because subcutaneous insulin को काम करने में थोड़ा टाइम लगेगा. यदि आप IV insulin इधर से बंद करो, subcutaneous दो, 2 hours would be there when there are no insulin in the body, or 1 hour would be there when there is no insulin in the body, और पेशेंट को फिर से कीटोएसिडोसिस में चला जाएगा. So there should be an overlap of 1 to 2 hours before you stop the IV insulin. Dose calculate करना कैसा करना है subcutaneous insulin का? There are 2 or 3 ways. One thing is you calculate how much insulin patient is requiring in last 24 hours IV insulin. You give the subcutaneous accordingly insulin according to that. If patient has just stopped the insulin, patient is already on insulin and there is no infection, you can start with the subcutaneous insulin whatever the patient was taking at home. But if the infection was there, you see the IV chart, how much insulin a patient has received in 24 hours, you decide the rate according to that. If patient is insulin naive, newly diagnosed type 1 diabetes, you can start with 0.6 or 0.7 units per kg per day. This is the approximate dose of the insulin that you should give to the patient. Use early insulin in basal insulin as well to prevent the rebound hyperglycemia during the insulin infusion. Cerebral edema usually seen in pediatrics age group, having high mortality. What the studies have shown, insulin dose in first 2 hours is significantly associated with high risk of cerebral edema, and it is not the rate of fluid administration which is responsible. If you diagnose the patient has become conscious, suddenly he loses consciousness, becomes drowsy, get a CT scan. CT scan is showing there is an edema, give the patient mannitol. Okay, patient has improved. What are the pitfalls? हमें एनालाइज भी तो करना है, हम कहाँ कहाँ गलती कर सकते हैं. What are the pitfalls in the management of diabetes ketoacidosis that you should be take care? Not assessing or treating the underlying cause of diabetes ketoacidosis. Ketoacidosis तो बना लिया, लेकिन पेशेंट को ये सोचना है पेशेंट कीटोएसिडोसिस में गया क्यों. Either it is a stoppage of insulin, okay, or patient has developed some infection. पेशेंट को निमोनिया है, निमोनिया का IV एंटीबायोटिक नहीं दिया, पेशेंट ठीक नहीं होगा. Or patient has got myocardial infarction, must get an ECG. It would tell you about potassium level, but it could also tell you patient might have silent myocardial infarction. 35 years old male है, diagnosed है डायबिटीज़ का, पिछले 5 साल से डायबिटीज़ है, और 40 years male है, आपके पास आया, young patient है, silent myocardial infarction might be there, and you are missing altogether. Must get an ECG, look for a precipitating cause. If you don't treat the myocardial infarction, just treat the diabetes ketoacidosis, you might not be able to save the patient. Look for the underlying cause. Patient is unconscious, सेंसोरियम इंप्रूव नहीं हो रहा, लुक के पेशेंट को देख लो या कहीं पेशेंट को सेरिब्रल वास्कुलर एक्सीडेंट ही ना हो साथ में. यू हैव टू ट्रीट इट अकॉर्डिंग टू दैट. पेशेंट वाज हैविंग माइल्ड पेन एब्डोमेन, पेशेंट का पेन एब्डोमेन नहीं ठीक हो रहा, आपने IV फ्लूइड भी दे दिया. लुक फॉर यार कहीं पेशेंट को पेनकेटाइटिस ना हो, अंडरलाइंग कॉलिसिस्टाइटिस ही ना हो. Look for the underlying cause. Take care of these things. If you don't take care of the underlying pathologies, patient would never improve. Not watching potassium closely and monitoring replacing the potassium aggressively. Almost all the patient of diabetes ketoacidosis will require the potassium replacement. If you don't replace the potassium, patient are going to have hypokalemia, patient is going to have arrhythmias. The third thing is falling urine ketones rather than serum ketones. यूरिन में कीटोन्स बहुत लेट डिसअपियर होंगे, सीरम कीटोन्स जल्दी हो जाएंगे. सो ब्लड कीटोन्स कराने हैं, सीरम कीटोन्स को फॉलो नहीं करना. इंटरप्टिंग IV इंसुलिन टू सून, कि पेशेंट का शुगर तो कंट्रोल हो गया, चलो यार अब IV इंसुलिन की ज़रूरत नहीं है, पेशेंट हाइपोग्लाइसीमिया में ना चला जाए. नो, यू हैव टू गिव IV इंसुलिन टिल द एसिडोसिस हैज डिसअपियर्ड. You have to give dextrose along with insulin. Don't stop the insulin when the blood sugar has just come to 50. Unless acidosis is corrected, patient would never improve. Then occurrence of rebound ketosis consequent to inadequate insulin dosing at transition. आपने सबक्यूटेनियस इंसुलिन नहीं शुरू किया तो पेशेंट को रीबाउंड कीटोसिस हो जाएगा. चलो ये भी कर लिया आपने, सबक्यूटेनियस इंसुलिन भी दे दिया, पेशेंट इंप्रूव भी कर गया, पेशेंट खाने पीने भी लग गया. बिफोर डिस्चार्ज You have to give the patient, tell the patient that he should not develop the ketoacidosis again. Sick day rules patient को समझाने हैं. If the patient gets an infection, patient gets the fever, patient has to travel outside, how he should carry the insulin, what are the precautions if the patient becomes ill, क्या करना है उसने उस समय. I tell the patient is having nausea, vomiting, patient is not able to take any much orally. Diabetic patient है. अब पेशेंट क्या करेगा, सर मेरे को वॉमिटिंग हो रही थी, फीवर हो रहा था, मेरे से खाया नहीं गया कुछ भी, इंसुलिन बंद कर दी मैंने, खाया ही नहीं जा रहा तो मैं इंसुलिन नहीं लूंगा ना, मैं हाइपोग्लाइसीमिया में ना चला जाऊं. नो, द पेशेंट वुड लैंड अप इन डायबिटीज कीटोएसिडोसिस. ए पेशेंट टाइप 1 डायबिटीज और पेशेंट टाइप 2 डायबिटीज हु इज ऑन इंसुलिन is not able to take much, not able to eat much, he should take small fluids, small amount of fluids, might be with some sugar and with some of the नींबू पानी बना के उसमें थोड़ी सी चीनी डाल के पीता रहे. Check his blood sugar repeatedly and depending on the blood sugar he has to take the insulin. If the patient is able to take orally and patient is having fever, acute infection, his blood sugar would rise. Why? Counter regulatory हार्मोन ज़्यादा होंगे, cortisol ज़्यादा होगा. Diabetic patient able to take it or able to take consume orally, having the fever, he should increase his insulin dose by 25% if the ketones are positive. Then the third thing patient पूछता है कि मैंने ट्रैवल करने जाना है, मैं सर घूमन जाना जी, आज अपने हिल स्टेशन पे जाना है. How should I carry my insulin along with that? मैं 5 दिन लिए बाहर जा रहा. कल भी मैंने एक बड़े बंदे ने पूछा, मैं दुबई घूमन जा रहा सर, 5 दिन लिए मैं इंसुलिन बंद कर देना की फर्क पैंदा, कित्थे लेके जाऊँगा, मैनू प्लेन वाले मना कर देंगे इंसुलिन लेके जाना. नो, यू हैव टू कैरी इंसुलिन अलॉन्ग विद यू व्हेन यू आर गोइंग आउट. हाउ यू शुड कैरी इट, आई टेल द पेशेंट, एक तो है इंसुलिन आइस पैक्स में ले जाओ, बट यूजली वो 4 to 6 आवर्स रहते हैं और कई जगह रेफ्रिजरेटर नहीं मिलता, तो उसमें आप होटल में ना रेफ्रिजरेटर नहीं मिलता, वैसे ठंडा हो जाता है लेकिन उसमें फ्रीज नहीं होगा, फ्रीज़र नहीं होता, उसमें जमेगी नहीं इंसुलिन आपको यदि लेके जाओगे. तो हाउ आई टेल माई पेशेंट हाउ यू शुड कैरी द इंसुलिन लॉन्ग विद दैट. एक थर्मस ले लो, थर्मस जो कि बच्चे पानी लेके जाते हैं जिसमें ठंडा रहता है पानी, उसमें आइस पैक, उसमें उसमें इंसुलिन रख दो प्लास्टिक के लिफाफे में और ऊपर से बर्फ़ रख दो, आइस रख दो. कहीं भी जाते हो 6 घंटे बाद आपने कहीं खाना खाने रुकना है, इत्थों दिल्ली जाना यार, दिल्ली जाना, दिल्ली जाके फ्लाइट पकड़नी है, नाल ले जाओ, कितने रोटी खान रुकोगे, जिथे खाना खान रुकोगे, किसी रेस्टोरेंट 'ਚ रुकोगे, अपने यूजली सुखदेव ढाबे रुकते अपने सारे पंजाबी, वहाँ पे रुके, वहाँ पे जो अपनी वो बर्फ़ का पानी बन गया उसको फेंक दो, वेटर को बोलो नया बर्फ़ उसमें डाल दो, अगले 6 घंटे आपका इंसुलिन फिर से कैरी हो जाएगा. फिर पेशेंट मेरे से पूछता है सर मैं फ़्लाइट में कैसे लेके जाऊँगा, मुझे तो दुबई जाना है, मेरा तो प्रॉब्लम हो जाएगा, अंदर इंसुलिन लेके नहीं जाने देंगे. वट द पीपल टेल यू कि फ़्लाइट वाले क्या कहते हैं, 100 ml तक लिक्विड लॉ करते हैं. क्या मेरे को किसी एयरपोर्ट वाले ने बताया था कि 100 ml से लिक्विड से ज़्यादा लेके जाओ तो उससे बॉम्ब बन जाता है. तो मैं क्या कहता हूँ पेशेंट को क्या करना है, जब आपने सिक्योरिटी चेक के लिए जाना है, मेरा स्लिप साथ में ले जाओ कि आपको इंसुलिन की ज़रूरत है. जब सिक्योरिटी पे गए, थर्मस में अपनी इंसुलिन रखो, अप टू 10 वायल्स यू कैन कैरी, 100 ml हो गया, 10 ml की वायल है, जो बर्फ़ है सारी फेंक दो, सिर्फ बॉटल में इंसुलिन रखो. सिक्योरिटी को क्रॉस किया, वाइन वाली शॉप पे जाओ, वहाँ से बर्फ़ फिर से ले लो, बर्फ़ फिर से डाल लो उसमें. मुझे कहता है पेशेंट की बर्फ़ कहाँ से मिलेगी एयरपोर्ट पे और फ्लाइट में, वाइन वाली शॉप पे जाओ यार, हर जगह इंसुलिन मिल जाएगी ऑल ओवर द वर्ल्ड, वहाँ से बर्फ़ लेके उसमें डाल लो, आप इंसुलिन कहीं भी कैरी कर सकते हो. फिर पेशेंट पूछता है सर फिर से आगे से जब मैं सिक्योरिटी पे जाना है, फ़्लाइट पढ़नी है, फिर से मेरे को प्रॉब्लम आएगी, उस समय बर्फ़ फिर से फेंक दो, यदि वो सिक्योरिटी वाले कवर करते हैं, अंदर जो एयर होस्टेस है उसके पास तो बर्फ़ पड़ी होगी ना, उससे ले लो. सो यू कैन कैरी द इंसुलिन लॉन्ग विद इट वेयर एवर यू गो, and don't put the insulin in the luggage bag, always carry it in your hand, with your hands. Okay, then inadequate patient education and training can lead to ketoacidosis, and then you must call the patient of diabetes ketoacidosis for the follow up after 1 week and see how the patient is doing, because inadequate follow up would land up the patient again in ketoacidosis. ये बड़ा इंपॉर्टेंट है, SGLT2 inhibitor. For last 5 to 10 years we are using SGLT2 inhibitors and now GLP-1 receptor agonist in type 2 diabetes. होता क्या है, when you are using SGLT2 inhibitors, they shift the metabolism from glucose metabolism to fat metabolism, predisposing the patient to ketonemia and diabetes ketoacidosis during SGLT2 inhibitor use. And these patients might be having normal blood sugar and modestly elevated blood sugar, and yet they land up in ketoacidosis. So a patient who is using SGLT2 inhibitor is not feeling well, having nausea, vomiting, is dehydrated. You have checked his blood sugar is 200, but must check the ketones. And you can diagnose the patient having euglycemic ketoacidosis. Means blood sugar is less than 200, even then ketoacidosis is there. That's why criteria for diabetes ketoacidosis has now been changed. It is not only the high blood sugar, but presence of diabetes with ketones positive is ketoacidosis. So if you are diagnosed the patient to be suffering from diabetes ketoacidosis, what you should do? Patient is having on SGLT2 inhibitor. Stop SGLT2 inhibitor immediately if symptoms of diabetes ketoacidosis are there. If patient has to undergo emergency surgery, stop SGLT2 at that time. If it is an elective surgery, patient को cholecystectomy करना है, hysterectomy करना है, उसको 24 आवर्स पहले SGLT2 बंद करो. और एंटिसिपेटरी स्ट्रेस एक्टिविटी, पेशेंट ने मैराथन करनी है, बहुत ज़्यादा फिजिकल एक्टिविटी करनी है, इस संडे तो आपका बहुत भजना है जी, 15 किलोमीटर की सैर करनी है, सैटरडे संडे SGLT2 नहीं लेने, फ्राइडे ले लिया बहुत है. एंड थर्ड थिंग, डायबिटीज कीटोएसिडोसिस इन SGLT2 measure blood ketones. Urine ketones might be negative and only blood ketones might be positive. What are the precipitating factors for SGLT2 induced diabetes in SGLT2 patient for diabetes ketoacidosis? There is a mnemonic derails. What it is, if the patient having decreased intravascular volume like diarrhea, vomiting and exercise, it can lead to ketoacidosis. Or ketones prone states like reduced oral intake, alcohol intake, inpatient hospitalization, LADA, latent autoimmune diabetes in adults, or surgery. These can lead to ketoacidosis. So you have to be extra careful about these patients. What are the complications of diabetes ketoacidosis? Hypokalemia and hyperkalemia, you have to monitor the potassium and correct it accordingly. Hypoglycemia, you have continued to give the patient insulin and have acidosis persisting but have not started with dextrose. So when the blood sugar falls less than 250, must give the patient DNS or dextrose 5%. Cerebral edema in pediatrics age group. How I would summarize my talk. Diabetes ketoacidosis and hyperosmolar coma should be suspected any patient with diabetes who is ill. And if you diagnose patient to be suffering from diabetes ketoacidosis, look for precipitating factor and treat it. These are medical emergencies who are having multiple metabolic abnormalities. It is not that only high blood sugar is there. Patient is fluid deficit, patient might be having hypokalemia, and patient is having acidosis. You have not to treat only the high blood sugar. You have to treat fluids, you have to treat potassium, you have to treat acidosis. थर्ड थिंग, नॉर्मल पेशेंट आपके पास सिक आया, डायबिटिक पेशेंट, आपने सस्पेक्ट किया कीटोएसिडोसिस है, लेकिन उसका शुगर चेक किया, जस्ट शुगर इज 200 और 250, इट डज नॉट रूल आउट डायबिटीज कीटोएसिडोसिस, especially a person is pregnant or the person is using SGLT2 inhibitor. Euglycemic ketoacidosis is well known entity. Diabetes ketoacidosis requires IV insulin for its resolution. Thank you.